All right, everybody. Thank you so much for joining us. My name is Brandy Sylvan. I'm the Director of Government Relations at the Department of Community Health. So in that role, I serve as a liaison between the department and our elected officials, lobbyists, advocates, and so I'm definitely very involved during the legislative session at making sure the department is informed on any legislation that may impact our programs. And then, Maya, I'll let you introduce yourself.
Hey, everybody. My name is Maya Carter. I am in a different role than some of you probably remember me from. Hey, Mike. I started out here at DCH over the behavioral health program, which turned into managing several other programs. And when you manage a program, you wind up being responsible for all of the inner workings of those programs, meaning how do the claims get paid, how do prior authorizations work, what do I need to say when I go to this hearing. And so that turned into my new role here as Office Systems Support Director. So just like Brandy is a liaison, I too am a liaison between the legislative session agendas being mandated and DCH getting those things implemented into the system.
All right, thank you. So today we're going to do a very high-level overview with you about some of the legislation that passed in 2022. So for anybody that's not familiar with how the legislative process works in Georgia, our General Assembly meets every year for 40 legislative days. So that's typically about the first 3 months of the year. And that's the only time when they're able to kind of get in there and pass new legislation. They do operate on a 2-year session, so meaning that in 2022, that was the second year of a 2-year session. So any bills that did not pass in 2021 were still eligible for consideration in 2022. But now this year we'll be starting a brand new session, which means it's a totally clean slate. If you want to revisit a given bill or a given topic, it will have to be reintroduced and it starts the process over again. So today I'm going to kind of talk about some of the bills that passed this year, and then Maya will talk about where we are in implementation with some of those. And I know I said this, but this is super high level. This is certainly not an exhaustive list, and I won't be going into a ton of detail on anything. But if you would like to touch base with me after and get any more information on anything, I'm more than happy to do so. House Bill 412 allows for the licensure of applied behavior analysts. This goes into effect July 1st of 2023. The impact to Medicaid is that we will now be opening up our provider enrollment system to allow for the enrollment of these provider types as Medicaid providers. House Bill 918 creates the Rare Disease Advisory Council. That has already gone into effect and the council members have been named. One of the directives that medical assistance plans, as well as our state health benefit plan in DCH was given with this council, is that if we're going to make any changes to benefits or anything like that, that we would consider interacting with them to discuss those policy changes. House Bill 1013, this was sort of the big bill this year. This was the mental health parity bill. You've probably heard a decent bit about this. The Speaker, David Ralston, was the primary sponsor on this bill, which is a very unusual circumstance. That just kind of adds a little bit of gravity to how important it was to the legislature to pass this. But it is a very comprehensive bill that makes changes to mental health treatment in the state. It's certainly not limited to DCH, Medicaid. It addresses the criminal justice system. It's a very it's a broad bill. So I'm just going to hit on some of the changes that DCH will need to be making to comply with this bill, but that's not the entirety of the bill. DCH will be required to ensure that all of our plans are in compliance with federal parity laws. So when we talk about parity, That means that the benefits that are offered for your physical health care are going to be comparable to what you're offering on the mental health care side. Now, that's a very generic statement for what can get very granular, but it's attempting to kind of put those two benefits on the same level. We will need to have some parity reporting requirements. So that means for all of our plans, we will need to have a report published that shows how well we're doing with being in compliance with federal parity laws. We already have those compliance reports available from the CMOs. They have been providing those to us for a while, and they are available on our website, but we will certainly be expanding that to include our fee-for-service population as well as our state health benefit plans. It requires that a medical loss ratio is set in place for our CMO contracts of 85%. That means that there is a requirement that 85% of the funds that go to the CMOs is paid out in benefits. It directs DBHDD to create a match team. So the match team is intended to identify members that have high needs that may overlap multiple agencies, and to bring the agencies together to kind of review those on a case-by-case basis and determine how to best meet the needs of that individual. DCH is directed to conduct a rate study for mental health services. That study is already taking place. I believe it will be available early next year, I believe. Happy to follow up on that, though. And finally, it defines some coverage requirements under medical assistance plans for the treatment of psychotic symptoms with medication. Okay, House Bill 1276 requires that the department post on a biannual basis statistical reports about our plans. Those have been up for some time as well, and it's just a variety of plans of information. It's I think it's very helpful information about our membership, our benefits, our makeup. It's pretty comprehensive report that you're able to view now. House Bill 1324 is the prudent layperson standard. So what that means is if I, as a everyday citizen, believe I'm having a medical emergency and I present myself to the emergency room, and let's say it turns out to be heartburn instead of a heart attack, that the payment of that claim should not be denied because it was not an actual medical emergency. So the bill this year, there was some prudent layperson language already in statute, but that expanded it to include some mental health concerns as well. Senate Bill 338, this is one we've heard a lot about in the news, but this extends Medicaid coverage for our pregnant Medicaid members out to 1 year postpartum. So currently, you are able to have that coverage out to 6 months postpartum, but during the public health emergency, we've not been terminating anybody from our roles, so that means that, these women have been able to receive those services for longer than 6 months currently. But we did actually receive approval from CMS on this very recently, so I was very happy to hear that 12-month period will be in place before the end of the public health emergency and that we won't have any overlap there. And then the funds to appropriate the appropriations for that extension were included in our budget for fiscal year 23. Finally, Senate Bill 341 requires the coverage for medications for chronic conditions to a minimum of either 12 months or at the end of your coverage term. And so that goes into place January 1st, 2023. So on the Medicaid side, we're certainly having to make some program changes to ensure those prior authorizations are set up appropriately. Senate Bill 610 this has to do largely, originally it was a rate study bill for our waiver services, and it directs the department to conduct a rate study every 4 years for our waiver programs. And the intent there is to kind of look at what rates we're giving to providers and kind of comparing those with what rates we're seeing in other states, and giving legislators an opportunity to see if they wanted to adjust those rates in any way. The bill was changed during session and also added an IMD waiver exclusion. So that directs the department to submit a waiver to CMS that would allow for institutes of mental disease to bill as Medicaid providers. That waiver is to be submitted by the end of this year, and we are working on that. And then Senate Resolution 770 created a Senate study committee on people with intellectual and developmental disabilities and waiver access. So Brian Dowd, who is one of our Medicaid directors, serves as a member of this study committee. And they've already held several meetings, but primarily they're looking at the now and comp waivers. And they're interested in, finding out kind of what the planning list looks like, hearing from providers about challenges they're facing, and hearing from members about challenges they're facing. So that study committee will put out a list of recommendations at the end of this year, and I'm certain that the legislators will be looking to that to see kind of if they want to take any action this coming session. Okay, and then in Medicaid, there's certainly a lot of changes that are made in the budget. So while this isn't necessarily legislation specifically, these are budget directives that that we will be adding in as benefits. So first, the budget provides for increasing funds for the implementation of express lane enrollment. So what that means is that if a child is identified as receiving, I believe it's SNAP benefits, then they will automatically be reviewed for Medicaid eligibility as well. And so that is the goal of that is to have more children that are eligible for Medicaid benefits to be enrolled and receiving services. The budget provided funds to eliminate the provider attestation requirements, which allows primary care providers to receive enhanced rates. There was a previous requirement that in order to receive these enhanced rates, you had to have attested. This was part of the Affordable Care Act that kind of carried over. And providers that did not complete that attestation were ineligible to receive the enhanced rates. And so by adding this funding in, we can remove that requirement and allow all primary care providers to get the enhanced rate, which will be a tremendous help to, I know, many of our providers around the state. As I said, funds were provided to extend our postpartum coverage out to 12 months. There was funding provided for value-based purchasing, which is sort of I'm sure you are all familiar with that, but it's a mechanism for providers to receive an additional revenue based on quality outcomes. And then there is funding for the coverage of therapeutic and care management services, clinical trials, these were not previously covered, as well as coverage for donor breast milk. And then finally, there were several reimbursement rate increases. This is, again, not a comprehensive list, but some of the rate increases we saw this year were for long-term acute care facilities, ventilators, medical nutrition therapy, dental services, independent pharmacy dispensing fees, and several others. All right, and I'll hand it over to Maya.
Thank you, Brandy. Okay, again, my name is Maya Carter. The specific House bills that you saw, I just kind of want to talk to you about what needs to happen when those types of mandates get made, whether they're from CMS, whether some legislation has has passed, whether there's been a state plan amendment, all the moving parts that are required to turn that list into a living, breathing, billable thing in Georgia Medicaid. My role is I'm the liaison between the policy people and the system, the subject matter experts that tell us how they want this service to look, how they want this rate to be changed, how they want this different type of provider to be enrolled, and the provider enrollment team or the prior authorization entity or our DCH IT folks. I'm right there in the middle saying, here's what they want, how do we do this? So all of the House bills and all of those agenda items that you saw, whenever they are presented, they're prioritized. We meet weekly with our IT, we meet and Gainwell and all of the necessary parties. We prioritize them mainly by what's the effective date, what effective date is most important, but also sometimes our prioritization comes from our higher ups. And we break down every single moving part that has to be adjusted in order to make that happen. For an example, we talked about the institutions for mental disease. That may likely be a new category of service, or we may enroll that type of a facility into an existing category of service. Another example that she just listed was a rate study to possibly adjust mental health rates. So what does that mean? The existing rates for all the behavioral health providers, all the psychologists, all the psychiatrists, what needs to happen in the MMIS in order for that new rate to have an effective date? Is that rate going to have to touch PAs? Does that rate have to touch provider rate files? Does that rate have to touch edits that have dollar limits? There's a lot of moving parts, and I'm taking the time to explain this because we often get a lot of questions and a lot of pressure about why things take so long. It's never quick. It's always accurate, but it's never quick because we have to make sure we get no surprises when we turn a light switch on. So that's my role here. I tried to get as much info as I could about this listing. The only one that I know for sure has a SMR, which is a systems maintenance request that has been actively submitted and is being worked, even though we're still waiting on approval from CMS. One of the great things I love about our chief, Lynette Rhodes, we prepare our system to go live even if CMS hasn't approved it yet, because it's easier to turn it off than to wait and have to turn it on late. So we have gotten the effective date of the postpartum extension. The form that's needed to submit that change has already been submitted. Everything else is probably in a CSR status, which is a change system request, or a BRD status, which is a business requirements document that's being developed and discussed and tweaked again. So if there's anything specific you want to know, like exactly where we are with the system, please, by all means, email me, and I can connect you with the policy person, or I can check with that policy person and find out exactly where we are if you have concerns. My name is Maya Carter. My email address is mcarter@dch.ga.gov. mcarter@dch.ga.gov. Now we can open it up for questions.
While she's walking, I just wanted to add one thing onto what Maya said, talking about how a lot of times it takes us a while because we do get questions frequently about this was in the budget, or this bill passed, where is it, But there is definitely a process. A lot of these directives have to go to our board first, and that requires an initial adoption, a 30-day public comment period, a final adoption before we can even submit it to CMS. And then, CMS has their own process, and we can't move forward on anything until we have their approval. So it does take a little while on some of these, and I know that can be frustrating to providers sometimes. But I promise we are working diligently on our end to get all of this stuff off the ground as quickly as we can.
Yes, I have a question. They're doing some studies on the effect of COVID on young children, and what they're finding is that the children are not talking. So is this something that you would look at, increasing the rates for speech therapy under children's intervention services? Because the data's coming out that these kids are not talking. They're crawling, they're beginning to walk, but the words are not coming. So is this something that you're going to look at? Because we're part of maternal and child health, so we're like 0.9% of the budget. But our work is extremely important, the speech, occupational, and physical therapy services for children, because if we don't get these kiddos ready for school so that they can learn and progress and stay in school and get jobs, so they're less likely to require Medicaid services, but we get very little attention when it comes to increasing rates. I understand the doctors need increases, but we also face a lot of expenses. We have to keep electronic records. Our test for speech therapy, a test that used to cost $75 is now $600. And a test form is over $3. We're required to test every 6 months. And so, and with this new data coming out for COVID, is this something that the legislature can look at without us begging and pleading for rate increases, because we definitely need them?
So I can speak to sort of the process side of things, and typically how those rate increases come to be. So we receive a directive from the Governor's Office of Policy and Budget, and that is really what guides the budget requests that we as a department make. So for the past several years, we've had a flat budget direction, meaning that we as an agency are not asking for increases. So whenever we see these increases, they're typically added during the appropriations, the budget development process. And so often advocates, such as yourself and other individuals in your business, I know that you guys definitely have a presence at the Capitol, the speech therapists do. They would work with the appropriations committee members to kind of make that case for why these increases are needed. And it is up to the members of appropriations to look at that and see if they, have the funds to put in the budget to make it so that we can fund that increase. Did I miss anything? Oh, hold on. I think Lynette wants to add something.
And so one other thing I'll add to that, specifically as it relates to the PTs, OTs, and STs. So the Tri-Alliance is the provider association that represents all of those entities. We met with the Tri-Alliance last week. We are aware that they have intentions to reach out to the legislature regarding potential rate increases. So my recommendation to you would be that you reach out to the Tri-Alliance. Hopefully you are a member. Okay. So then they should be able to kind of give you some insight in terms of what their thoughts are. Yep.
She needs to be saying those things to the governor's office.
Perfect.
Yeah. The squeaky wheel get the grease.
Okay. They're working on it, is what I can tell you.
And I'll be happy to give you the names as well as as some of the appropriations committee members if you are interested in reaching out to them directly. Okay.
Okay, I have several questions, actually.
Sorry,
the
where
first
are you?
one is,
Jill, she's these questions are coming in from the
Oh, okay.
virtual room.
Okay.
one, okay. The first one is a three-part question. It's asking, will an updated, enhanced rate list be posted to GAMIS? Was there any changes, i.e. rates codes, to House Bill 76, 751, and 44 for 2022? And will there be an updated code and rate list?
So what specific, because, so the bills that are referenced are our budget bills. Do you want to just come up on it? But I'm not sure specifically which rates.
Right, and just a reminder, rates for our programs are always updated and kept in the policy manuals that are available online. And many times, if there's a big rate change, there is a banner message that's posted in advance of that listing. So I'd like to remind all of our attendees, all of our providers, to pay attention to your quarterly updated provider manuals in the appendices that list the rates.
And so I'll add some additional context. So House Bill 76, House Bill 44, and House Bill 751 are all related to attestation. And so these were bills that were passed after the rate increases under the ACA ended. So for those who don't recall, in 2013 and 2014, 2013 and 2014, CMS increased the rates for certain primary care physicians who had certain specialties. This was only for a period of 2 calendar years. So those rate increases ended December 31st of 2014. Because of the outcry from providers, we extended those rate increases for 3 consecutive years, and those are the House bills that the person is asking about. House Bill 44, House Bill 751, and House Bill 756. They were done in 3 consecutive years. Over those 3 consecutive years, we increased the rates for various codes. If I'm remembering correctly, I think it was a total of 108 codes total where those rates were increased. So what happened this year, and what the discussion has been over the past years, is that there were a number of providers who, for whatever reason, did not attest and did not receive those enhanced rates. So what Brandy mentioned to you earlier is that in this year's legislative session, we removed the attestation requirements. So now there's all of those primary care physicians who did not attest previously, but were eligible, but for the fact that they didn't attest, will now be able to get those rate increases. So yes, we will update those rate tables across the board to reflect what the current rates will be, and that's where that's kind of where we stand. So we're waiting to get approval from CMS on the removal of the attestation requirements, and then once that is done, we will push out those rate increases and update the rate tables. She had another. I'm sorry, I don't know if that answers all of those questions. I think it does.
All right. I know my question may sound a little bit ridiculous, but it's good to ask still. We know the law requires that people who work more than 40 hours a week are supposed to be paid a time and a half. Now, we get clients assigned to us, and based on their medical condition, they are approved for more hours than 40 hours a week. And nobody has ever talked about the extra hours beyond the 40 hours. And you know, because of what the economy is now, it's very difficult to get CNAs to work at anything below 15, 16. Many of them don't want to work. And so if you have a client that you have to provide service for more than 40 hours, and you are not willing to pay the CNA a time and a half, she's not ready to work. So you have to go look for another CNA who will take up the other one to make up. So I just want to ask, is anything being done, to discuss with the legislators? Since the law requires you to pay a time and a half, why is nobody talking about paying us a time and a half for clients that you all know has need for more than 40 hours a week? So can anything be done? Also about holidays, well, maybe holiday may be a stretch. It might be a stretch, but about 40 hours a week. Anything on that?
Yeah, so are you referring to waivers, the 1915C waivers? So I think your question at the end of the day is, are we preparing to give or planning to give a rate increase for CNAs? Is that what you're asking? Or,
Also recommends 50 hours of care a week for that client.
Right, so-
But we, the providers, are paid as if there is no extra time. So I'm just asking about the time beyond the 40 hours a week, because the law requires every employer to pay the employee a time and a half if the employee works more than 40 hours. So the only way we take care of that is look for another CNA to pick up the extra 40, what is above the 40 hours. So I'm asking, is anything being done legislatively to make us get a time and a half or something
no,
like that?
not legislatively, no, no.
Why not?
Well, that's a question for the legislature, sir. Right? So, yeah, so you have the, right. So that would be a question that would have to be posed to the legislature. So that's something I'll take back to my team to look at, but that's where we are right now.
Okay. The next question is about the attestation, and the question is, if it's effective back to 7/1, will Medicaid auto-process this, or will providers have to submit?
We will reprocess those claims. We will do mass adjustments on the fee-for-service side, and the CMOs will follow suit. So there will be no action required from the provider.
So regarding the attestation, will those changes be retro? I just want to clarify, the changes will be retroactive and not go forward?
The changes will be retroactive to the date identified in the legislation.
Which is 7/1 of '22?
Is it? Okay, then it should be 7/1 of '22. We'll confirm that. But
Okay.
let me just state for the record, whatever the date is in the legislation will be the retroactive date that we go back to.
Thank you.
Okay, I have another question. When we bill for family counseling H0004, parents are receiving statements that show ongoing drug services for this code. They are upset and concerned. The family group of codes fall into a category with a description of alcohol and/or drug services. Can this be changed? The child is 7 years old. It's family counseling, not substance use related.
So that sounds like a question that's specific to DBHDD's Community Behavioral Health Service Guidelines, and I'd be happy to liaison that inquiry to find out if there has been any updates to the family of codes. I know Rebecca Duggar is here. She might be aware of something, but they can email me, and I will make sure to get a response to them.
My question is, I just want to add to what he said about when you go to the legislatures about paying overtime, over 40 hours, if you could add also question about holiday pays.
I understand what you're saying. I understand what you're saying. I realize that there is an administrative burden when you're trying to offer enough coordination of care in a limited amount of time. However, as Lynette said, there isn't anything legislatively being done that allows us to make that change. The number of units per procedure code, per service that you're rendering, those limits are set by CMS. That's what you can bill, that's your maximum daily amount. So if you're working beyond that, that's an employee resource issue. So the maximum amounts are set, that's what's billable. If that can change, it may require you advocating with the governor's office, advocating with lobbyists, advocating with people that can affect that legislative process. But as it is, as far as Medicaid, what Medicaid can reimburse for, we can't pay you for overtime.
So, and I guess at this point, I kind of want to just reiterate what I said previously, and that these rate changes are not coming from the department, right? So these requests and making your case, I definitely encourage providers to do that. But it's appropriately directed towards your elected officials. So your, state House member, your state senator, I would definitely, start there, and then looking at any appropriate committee chairs. They typically have good open ears for conversations like these.
Okay. Is the state looking at increases for home care workers? When we have to pay CNAs $15 per hour and we are only being paid $20 per hour, how is a provider to pay for all the unfunded mandates required by the state, such as paying for RNs and office staff?
Same statement I just made. I definitely encourage you to talk with your elected officials and let them know the need for that rate increase. And anything you can do to kind of say, like, here's where we're at, here's why we need the increase, here's what we're seeing from not having that is what I would recommend.
And to make it clear why that advocacy is important. Speaking up in forums like this, that's awesome, but you need to speak up where the change makers are. I can remember when autism was not only not billable, but it was also an exclusionary diagnosis for Georgia Medicaid. Because of the advocacy, because of the lobbying, because of all the squeaky wheels, they got the grease, and now we have an autism program. So if you think Medicaid reimbursing its providers for overtime is something that's that important, if you think that an increase for speech, OT, and PT is that important, contact your officers, your legislatures, your senators, your lobbyists. It takes time, but the voices are heard and things do happen.
And, to that point, that is kind of the intent of the appropriations process, right? I mean, there are so many good cases to be made for needs across the state, and it is the job of our appropriations committee members to look at the resources the state has and determine how best to allocate those funds. And so that's why it does matter to speak up and be heard, because otherwise they don't even know that they should be considering you. But I also would like to say the directive we've gotten from the legislature to conduct multiple rate studies, I think is a good thing. It means that the legislators are very interested, that they're hearing from you all, that rates are not high enough. And that's why they want to see this rate study come out of our agency, because they want to see what other states are paying. What are they paying in the private world, so that they can make an informed decision on where is there the greatest need for more funding. Because, they have a finite bucket, and, they have to kind of make these very difficult decisions. But I think the rate studies are promising in that they recognize there's a need to look at that.
Got one more attestation question. The three bills, I believe, also had wording in there, so it only applied to recently licensed providers. Does the new language remove that, or is that still in there?
So
we have a couple that were licensed years ago, but never were treating Medicaid patients.
So I think what you're referencing is that the only people that well, one group of individuals that could get the enhanced rate that did not attest in 2013 were those that were newly licensed, that would not have been able to attest at 2013, in 2013. So that's probably what that language is that you're referencing. But yes, that's all, if you meet all the other criteria, the requirement to have attested in 2013 is gone. So it's not just for newly licensed physicians.
Okay, good, thank you.
One up here.
Hi, just a quick question on the postpartum rule. Will that start for deliveries effective 11/1, which is the date, or?
Correct. So effective November 1, we now provide 12 months postpartum from the date of, from the end of the pregnancy. Right. Okay.
But again, kind of going back to the public health emergency piece, you know, if you had had a baby in January 2020, you would still be, you know, you wouldn't have been terminated at 60 days. And so those women have all remained on. And so the fact that this got approved before the end of the public health emergency means that there won't be any gap there.
Any other questions? Okay, well, I'll be hanging around for a quick bit after this, if you want to. Oh. There's a survey, hold on.
We gotta close it out, they said.
Oh, that's what she was telling us. So take your phone out. I think this is one of those things where you get to click a link and engage.
Now what? It's not on the screen.
No. Did you take the other one down?
I did.
You ready to see? Not coming up. Her escape button is not letting me. If you go to menti.com and use the code 728-13332. He's going to put it up in just a minute. On your phone. You using your phone? Everybody has their phone? Oh, yeah. You ready? There it is. You see it at the top of the screen? menti.com. And the code is 728-13332. Let me know when you're ready. Show of hands. We're ready? Okay, very good.
I need to see some more hearts.
Okay.
I'm just saying.
Ooh, how did you attend the Georgia Medicaid Fair? Person? Virtual? And person has it. Okay. Ready? Next question. What was your overall satisfaction with the legislative changes session? Come on. Right. Oh, very good. Very satisfied. Very good. Okay. Next. If you were dissatisfied, please tell us how to improve this session. Okay. We'll take that information.
Okay.
Next, what was your ooh, they're quick. Ooh. I don't even need to read it. Very good, very satisfied. Okay. Very good. What was your overall satisfaction with the opening? Okay, okay. Look at the smart group. They got it. They got it. All I got to do is click the button. Very good. We have one more. Okay. You're dissatisfied, please tell us how to improve. And one more. Very good. Very good. Very satisfied. Thank you. Appreciate that. If you are dissatisfied, please tell us. You just type that in on your phone. And if you have any place you'd like to see us come, please let us know. You can just text it in. Augusta, Atlanta. Okay. That's it. Thank you so much for your time, and hope you enjoyed. Thank you, ladies. Very good.